Hello everyone, my name is Brian Erb, and today I'll be presenting my mental health screening reminder change project. This is for my class in Nurse 691B Culminating Experience 2. My instructor is Dr. Deborah White, and it's through West Coast University. So without further ado, let's get started here. The primary topic of my change project is the introduction of an email reminder system to boost mental health screening rates in the primary care setting. Mental health disorders affect nearly 1 in 5 U.S. adults, but out of those affected, only about half receive treatment. This project targets adults ages 18 through 65 using tools like the PHQ-9 for depression or the GAD-7 for anxiety. The PICO question guides this project, focusing on a measurable increase in screening completion over 1 month. And it goes as follows here. For my population, adult patients 18 through 65 years in a primary care clinic, implementing an email reminder system for annual mental health screenings for intervention compared to standard care without reminders for comparison, increase screening completion rates for outcome over 1 month for time. This problem stems from a widespread underutilization of mental health screenings in primary care, leading to a delay in diagnosis and treatment for conditions like depression and anxiety. At the clinic, which serves around 2,000 adults annually and transitioned to EMR in 2022, screenings were often overlooked. On average, for the national screening rates, we see around a 30% screening rates in the general population. However, based on research for interventions such as these, a potential increase of around 45% can be achieved with interventions such as an email reminder system in place. I chose this project based on direct observations and rotations where screenings were inconsistently applied. The 18 to 65-year-old age groups are particularly vulnerable, and as a PMHNP, I'm positioned to advocate for technology-driven solutions. It addresses nursing's emphasis on prevention and aligns with the APNA's standards focus on integrated mental health care. For the organization, this project adds value by boosting screening to decrease untreated cases and emergency visits, aligning with the quadruple aim. It could increase revenue and save costs through prevention while embedding a culture of proactive care led by PMHNPs. Now let's delve into the literature review of my project. So my literature review covered recent peer-reviewed sources, revealing strong support for digital reminders and mental health screening. Overall, they enhance the adherence and efficiency in primary care settings. A few of my key studies included Haleem et al., which reviewed telemedicine capabilities and stressed email and digital tools' role in overcoming barriers to mental health access. Features like automated reminders improved adherence by 15 to 20% in primary care settings. Zhao et al. Conducted a systematic review on digital patient portals and found that portal-based reminders enhanced health outcomes and efficiency, with mental health screening uptake increasing by 12% in integrated systems. Sligo et al. Evaluated a web-based mental health screening tool called StepCare in general practices, and it showed improved identification of at-risk patients and treatment recommendations, with acceptability high among providers. The strengths of the first study included that it provided a substantial overview of telemedicine applications, including practical examples for mental health. The weakness was that it lacked specific quantitative data on screening effectiveness, relying more on qualitative descriptions. The second study's strengths were that it included a strong systematic review of methodology, including rigorous inclusion criteria and meta-analysis elements. The weaknesses were that it primarily focused on portals, not standalone emails, limiting direct applicability to simpler reminder systems. And the strengths of the third study were that it included a real-world application in general practice, offering practical insights for implementation. Weaknesses included that it was a small sample size, which reduced statistical power and generalizability. Rin et al. Tested a digital screening system called TEACH in primary care, showing significant increases in adolescent and mental health assessments adaptable to adults. Sligepin surveyed GPs and NPs on electronic reminders and found positive attitudes towards their use for preventative care, including mental health. Kemp et al. Reviewed email reminders for vaccines, analogous to screenings, reporting 10 to 15% uptake and improvements. The strengths for my Rin et al. Study included that it was an RCT design that provided high-level evidence for causal impacts. Weaknesses were that it included that it was adolescent-focused, potentially limiting direct application to the project's adult population. The strengths of the next study were that it captured provider perspectives, essential for adoption and feasibility. Weaknesses were that it was survey-based, relying on self-reported data, which may include bias. And the strengths for my Kemp et al. Study were that it included quantifiable improvements, providing a benchmark for reminder efficacy. Weaknesses were that it was vaccine-focused, not directly mental health specific, so stigma barriers were unaddressed. Sadesavam et al. Found behavioral nudges and reminders ineffective for VA mental health appointments, suggesting that patient-customized content is key. Bradford and Rickwood examined e-screening implementation, citing feasibility and benefits like reduced stigma, but barriers, including digital literacy. Boucher and Riker reviewed engagement in digital mental health interventions, noting retention challenges, but potential for reminders in primary care. Crossman et al. Studied mental health screening and general practices as a means for enhancing uptake of digital mental health interventions and showed improved identification via web-based tools. The strengths of the Sadesavam study included a pragmatic trial in real-world VA settings, increasing external validity. Some weaknesses of the study included ineffective results, which may discourage adoption without context. The strengths of the Bradford study included that it was a systematic review, synthesizing evidence on e-screening for youth. Weaknesses included that it was youth-focused, less directly applicable to adults. And some strengths for the Boucher study included a narrative review on engagement and retention, which is critical for reminder sustainability. Weaknesses were that it was a narrative, not systematic study, and potentially subjective. The strengths of the Crossman study included an observational cohort linking screening to digital intervention uptake and real practice integration, with high relevance to primary care, and it quantified improvements in patients with an at-risk identification. Weaknesses were that it was a cohort design, which is susceptible to confounding variables. The intervention involves sending automated email reminders from the EMR to notify patients of due screenings, with educational tips involved. To address obstacles like the digital divide, we'll incorporate hybrid methods and training. As a PMH&P, I'll oversee design and analysis. Also over here, we can see Appendix A shows a sample email template and what that might look like being sent out to a patient. The project aligns with the Plan, Do, Study, Act model for iterative improvements, the health belief model to motivate via perceived benefits, and the health promotion model for self-regulation. These frameworks ensure the intervention is research-based, addressing behavioral and systemic aspects. My project aims include notifying 100 eligible patients, auditing weekly, and targeting a 5% screening increase through automated, patient-preferred reminders. Values emphasize stakeholder benefits like prevention and cost savings. Outcomes focus on increased screenings, better detection, and sustained changes, aligning with the holistic care model. Implementation follows the PDSA, planning templates, executing SINs, studying via audits, and acting on adjustments. Workflow involves EMR integration for efficiency, with remedies for obstacles. Resources include a minimal budget for EMR tweaks and training. The PMH&P drives it for preventative gains with a 1-month timeline. Outcomes are measured by rate increases in audits, expecting reduced untreated cases. Organizationally, it enhances efficiency, revenue, and nursing's role in mental health. A few recommendations include scaling with hybrids and advocacy. In conclusion, this project advances preventative care, underscoring nursing's role in holistic care. Thank you so much for watching.